Shreya. So I'm actually a first year medical student at USF's med school down in downtown. I'm still a student and I do not have my doctorate, just so you know. So I'm giving you my knowledge to the best of my ability. I actually put a couple of slides in here that we had in our cancer courses. So we had like a couple of very specific lectures on breast cancer. So we did talk a lot about this. And all of that information is coming from them. So it's accurate information, but you just need to, in case you put this anywhere, you need to have that kind of as a caveat, right? So I'm not giving medical advice to anyone. I'm just telling you what's in the data and what I've been taught thus far. Okay. Amazing. Okay. So I also combined a couple of the questions you guys asked into kind of one. Just so you know that going forward, if it sounds like I didn't cover some things, okay? You guys can ask questions later if you have questions about that. Okay. So what factors can increase a woman's chance of getting breast cancer? So the first thing I kind of want to go over is there's something called a two-hit hypothesis in biology for cancer, which means that for every gene we have in our body, we have one from our mom, we have one from our dad. So we have two copies of every gene in our body. In order to get cancer, you need to have a mutation in not one, but in both of those genes, right? So as long as you have one normal gene, it will take control and it will make sure nothing haywire is going on. The biological basis of cancer is uncontrolled and abnormal growth, right? So usually the genes that cause cancer are the genes that control what they call proliferation and apoptosis or death, right? So if you have a gene that is what they call a checkpoint, right? So every cell, when it goes through its cycle, there's a checkpoint where your body will say, okay, you're gonna keep living, or we're done with you. You don't need to do anything anymore, and you're gonna die, right? And that's how we make sure we don't have too many cells in our body, but we also have enough. So there's a balance there between growth and death, right? And we need both. So any of the genes in our body that control either of those mechanisms, when they are mutated, that is what causes cancer, right? And not just one, but both genes have to be mutated. So this two-hit hypothesis basically tells us that even if you have one quote-unquote hit, that's not enough to cause cancer, right? So we hear a lot about, especially like breast cancer, the genetic component of things, right? If your aunt has breast cancer, if your cousin has breast cancer, if your grandmother had breast cancer, that gives you an increased chance of also having breast cancer. While it is true that you stand to inherit the gene that is mutated, it doesn't necessarily mean you will get breast cancer, right? It just means that in that two-hit hypothesis, you already have one hit. So let's say, so you're just at more of a risk. Say let's say you have a second hit. Now you have cancer versus somebody else has that same hit, that same mutation, but they don't get cancer because they don't already have one mutated gene, right? So that's the idea. And so breast cancer is actually considered what we call a multifactorial disease. So not only do you have a genetic component, but you also have a environmental component to that. So that's like diet, where you live, how much you exercise, what kind of work you do, all of that kind of stuff, right? So, and that is actually more of a factor in whether you get cancer than your genetic component. Your genetic component does increase your risk by quite a bit for the individual person. But if you look on a wide spectrum of all the people that have cancer, most of that is due to environmental and not genetic causes. Does that make sense? Okay. So I think that's something that if you're thinking about informing people about, that is a really good point to hit on, because I feel like a lot of people think that breast cancer is a genetic thing, and if no one in your family has breast cancer, then you probably won't get breast cancer. That's not true, right? 1 in 8 women, if you think about that, that's a lot of women, right? And not 1 in 8 women, if you ask them, have his family history, a pertinent family history of breast cancer, right? So that goes to show that more than just that genetic component is worth thinking about. So even a lot of us, maybe we aren't thinking, breast cancer is something that's in the cards for us, but it's still possible, right? Even if we don't have that family history. And that environmental aspect is very important. So that's maybe something you guys could talk a little bit about when you're informing people, right? So now we want to talk about, okay, so what are those environmental factors, right? We have infectious agents, smoking, alcohol consumption, diet, obesity, reproductive history, UV rays, so occupational, meaning, houses used to have asbestos in it, which is like a chemical and stuff they put in the walls for insulation, and that was poisonous and they didn't know it. So asbestos is something that a lot of construction workers have an issue with. Medications. So certain medications can cause mutations that can lead to cancer, right? But the issue is they still have to give those medications to treat other things, but they give it to you with the caveat of saying, this does increase your chance of possibly getting cancer, right? Infectious agents. Any of you heard of HPV? Right? HPV is a virus, so that's an infectious agent. But if you are ever infected with HPV, it greatly increases your chances of cervical cancer, right? So that's an example of an infectious agent. Not too much of an issue with breast cancer, but this is just like carcinogenic factors in general for a lot of different cancers. Alcohol consumption, diet, and obesity are 3 really big ones to focus on, especially for breast cancer. People are like, alcohol consumption, what does that have to do with anything? People really underestimate the damage that alcohol does to your body. And especially in American culture and a lot of cultures, drinking is kind of integrated, as you guys will see when you get older, into a lot of different things that people do, right? And certainly like a little bit of drinking doesn't hurt you, anything in moderation, right? But alcohol consumption, especially for people who have a history, that's something doctors will tell you a lot of the time to really try to avoid that. Something I will talk about in the future is anything that causes inflammation in your body is something that can make your body more prone to cancers. So alcohol is something that increases inflammation a lot in your body. Obesity is something that increases inflammation a lot in your body, and that kind of is like associated with a lot of cancers. Reproductive history, that is an important one for breast cancers. You'll see a word called parity. So parity means how many times you've been pregnant, right? So women with high parity have a lower incidence level of cancer than women who have low parity. So women who don't have never been pregnant at all and have had no kids, I think their risk of breast cancer goes up a decent amount. Not saying it causes breast cancer. That's not, and I'll say that this whole presentation, there are a few things that we'll say like is causing breast cancer. What's causing breast cancer are gene mutations, right? The other things are correlated, they're associated. They're in a lot of people who do show up with breast cancer, right? We can't say like this causes that directly, right? So we're not saying that not having kids causes breast cancer. That's not what we're saying. But we're saying that people who have not had kids, if you look at the statistics, are less likely to, or more likely to be the ones that have breast cancer for whatever reason. Okay. So strong familial aggression, autosomal dominant. Anyone know what autosomal dominant means? No, okay. We haven't got there. Okay, it's a biology thing. Basically, it's a pattern of inheritance. Um, let's say mom has breast cancer, right? She has the mutated BRCA gene. And she had like a second hit, right? If she has a kid, that kid will have a mutated gene. That is what autosomal dominant means. Okay. All right. Okay. Also, so this kind of thing, I kind of lumped it in with um you had that question that was like most people who have or like it's like 10% of people who have genetic incidents for those who have breast cancer, and like so majority of people are due to other factors, right? So I kind of lumped it in with that. So just so you know. Okay. How can women lower their chances of getting breast cancer, right? So we talked about a lot of this kind of stuff. Alcohol is a big one, exercise, diet, all of that kind of goes in with the idea of diabetes, right? If you are diabetic, your body's in this state of like inflammation because there's so much sugar in your body, and your body's trying to get rid of it, right? And so the same way that your body is trying to get rid of like infection, it causes all of this inflammation and it causes a reaction in your body, and all of that work is going towards trying to get rid of that, and it kind of causes a destructive environment, if that makes sense. And that does create kind of a breeding ground for cancer. People who have Crohn's disease, they have a lot of inflammation in their gut. They're much more likely to get disease cancers that have to do with your gut. Angiogenesis is a fancy word for growth of blood vessels. So a lot of people who are diabetic, they'll have issues with their vision because there's so much growth of blood vessels, and the blood vessels burst, and there's blood leaking everywhere. It affects your vision, right? That's why people with diabetes have to get their eyes checked. And then something that's very, very characteristic of cancers is they have a lot of blood supply, right? In order to grow, they're growing very, very fast, right? And in order to get all the nutrients and oxygen and all the stuff they need to grow, they need blood vessels. They need blood vessels to bring them all of those things. So something that you'll see cancers that are a high grade is that they have a lot of angiogenesis, or they have a lot of blood vessels. So anything that so people who are diabetic have a large level of angiogenesis. That's something that also kind of is creating that scaffold that's like perfect for a tumor to grow, right? Hormone therapies, that's a big one. So certain breast cancers are associated with estrogen, right? So they call them ER positive cancers, estrogen receptor positive cancers. So people who are exposed to a lot of estrogen, they have a higher association with getting breast cancer. So people who take oral contraceptives for a very long time, right? That is associated with higher levels of estrogen exposure. So that can increase your chances of breast cancer. Hormone replacement therapy, a lot of people, are going through that. And something that their provider will tell them when they start them on therapy is this is going to increase your hormone levels a lot, and that may increase your chances of cancer, right? So that's really important to keep in mind. No one tells you when you take birth control pills that is a side effect, but good to know, ladies. That is a side effect of birth control pills. They have a lot of side effects. This is one of them. Okay, what does HER2 status of breast cancer mean? So HER2, so all of these things, HER2, BRCA, anything else that you might hear, MYC, there's a lot of them. All of these are basically proteins, right? They're genes that encode for proteins, right? That's the central dogma of genetics is you have a gene, it turns into, so that's DNA, it gets turned into RNA, it gets turned into a protein, right? And that protein will do things that it needs to do in the body. So HER2 is a certain kind of protein that is a receptor, right? So it lives in the plasma membrane of a cell. And basically what it does is it's a growth receptor. So if there's growth factors, certain cells can release, we won't get into the biological mechanism of things, but if we need to proliferate, right? We have the death mode and we have the proliferation mode. If we need to proliferate, the epidermal growth factor receptor, HER2, is basically what will get that signal and say, hey, we need to grow. We need to grow, right? So overexpression of that receptor is associated with cancer, and so especially breast cancer. So that's something that's called an oncogene, right? So before it gets mutated, it's called a proto-oncogene. And that's a good thing. We want proto-oncogenes, right? Because they help us grow when we need to grow. Helps us increase the number of cells when we need to increase the number of cells. So we want that. We like that. HER2 unmutated is good. We want that. When it gets overexpressed like this, right? Or if it gets mutated, what can happen is it turns into what we call an oncogene, which means it is the source of overproliferation, which can lead to cancer, right? Okay, so that's what that means. So whenever, let's say, a provider will make a diagnosis of breast cancer, you take a biopsy of the tumor or you take a biopsy of the lymph node wherever they find the cancer, and they look for all these different proteins, right? Does it have HER2? Does it have BRCA? Does it have this? Does it have that? What does it have estrogen receptors? Does it have progesterone receptors, right? All these different kind of things they look for, so that they can know how to treat the cancer, right? Because certain cancers are not HER2 positive, certain cancers are not BRCA positive, and so based on those things, you can kind of modulate what kind of treatment plan you create for that person, right? So that's really important. This is a big one. BRCA is a very big one, as we'll see. So what does a grade of breast cancer mean? So there's two ways we look at prognosis, right? So prognosis is basically what do we foresee as being the outcome for this patient, right? How long is their survival rate? How is their quality of life? How aggressive is their treatment? All of those kind of things we consider as prognosis. What is the prognosis of this cancer? So the two things we look at two different things. One is grade and one is stage. So grade describes how abnormal that cancer is, right? So proliferation can just be the same kind of cell kind of growing over and over and over and over again. So you have this huge overgrowth of cells, but the cells still look normal. If you took like 4 or 5 of those cells and compared them to normal breast cells, they would look the same, right? It kind of gets worse when you look at those cells under a microscope and they look all kind of in different shapes, different sizes. We call it dysplasia, right? So we have hyperplasia, which is just rapid proliferation of that cell and that type of tissue. We have dysplasia. And dysplasia is where we get into those higher grade cancers that have less of a good prognosis because they're more aggressive, right? So a higher grade is obviously a more aggressive cancer that's associated with a poorer prognosis. And then staging has to do with how much spreading is there of that cancer, right? And how how much of the cancer is there. That's what staging refers to. So they typically do a TNM scale for breast cancers. So we look at the size of the tumor, right? So 2 millimeters, 2 to 5 millimeters, sorry, 20 millimeters, 20 to 50 millimeters, more than 50 millimeters, that kind of thing. So in situ is just a fancy word for it hasn't gotten through your skin, right? Basically, cells have something called a basement membrane, and it prevents everything from going kind of like into the internal environment, into your bodies where your organs are. So we don't want that, right? If it stays above that layer, we can remove it really easily. And 40% of cancers can be fixed by surgery just by doing that, just by removing that. However, if it's gotten through that layer, that's an issue, right? And that is what we call metastasis. So N is for regional lymph node involvement. So lymph nodes are basically these little ducts that are in different regions of your body. So you have a bunch in your armpit right here, and they remove any nasty debris or anything like that that's going through, that's in your tissues, wherever it may be. So if you have a tumor growing somewhere and it's releasing all this like nasty gunk, some of those cells can end up in your lymph node, and then your lymph goes all around through your body. It's kind of like your circulation. It's like your blood. It eventually jumps into your blood too. So once that cancer cell gets into your blood, it can go anywhere, right? It can go to your lungs, it can go to your brain, it can go to your heart. That's very bad. So the more metastasized we say that the cancer is, so the more spread it is, the worse prognosis, right? And we can't treat those things. So once a cancer has metastasized, that's when we start using chemo. That's when we start using radiation, because that type of thing, it impacts your whole body, right? And that's not very fun for the patient. It has a lot of different side effects. So we try to catch cancers quick because we don't want it to get to the point where it's going to be really hard for us to treat. And that has a much worse prognosis if it's metastasized. So typically, so something can have a really high grade but a low stage, and that still has a good prognosis. So that's kind of a hard concept to wrap your head around. I can have a grade 3 stage 1 cancer, right? We can do surgery and we can cure that person. No problem, right? But I can have a grade 1 like stage 3 M1 cancer, and that's going to be hard to get rid of. And we know that cancer is going to progress, and that's where we do aggressive chemo and radiation and hope for the best, right? So it's hard to say, because a cancer is grade 1 or 3, how bad your prognosis is. What we look more of to see the prognosis is the staging, because that kind of tells us where our limits are in terms of treatment. Okay. This is a slide from one of my lectures. And so see how it says 5-year survival rate for breast cancer patients on the left column? And it says stage dependent, right? So it's dependent on how much it's spread, not necessarily how bad the grade is, right? So that's important to remember, because if the cancer is really bad and it's growing like crazy, but it's all above your skin, we can take that out. We can take the breast out and nothing will, it'll stay gone, right? So that's like best case scenario. So people hear grade 3 and they get scared, but what we're really looking at is what stage it is, right? Staging is very important. Okay. These are all the risk factors. Age, gender parity. Remember, so some males do get breast cancer. It's very unlikely. The incidence is very low. What is the reason for that? Probably just the fact that biologically breast tissue in women tends to grow more, and so you have more incidence of proliferation in that area with women, right? But it's still possible. Lifestyle, dense tissue, we'll talk about that, genetics, family history. So only 2 to 6% of breast cancer is hereditary. 80% of those hereditary cancers are BRCA positive. Okay. So yeah, that's great. So most of it is environmental, which is, people forget that. Okay. Restrictions are on diet or activity after breast surgery. So obviously, after any surgery, we don't want a lot of exercise. Your body's recovering. You want to avoid anything that you're lifting that's heavy, any kind of vigorous aerobic exercise or anything like that. You don't want your stitches coming out. You also don't want your body working. Your body's already working overtime to kind of recover from the surgery. So surgery is trauma on your body. So you want to give your body time to recover from that. A lot of times when they do mastectomies, they'll put something in called a chest tube, or like a chest drain. And because there's a lot of inflammation in that area, so trauma causes inflammation, a lot of fluid is going to accumulate there, a lot of gunk is going to accumulate there, and we don't want too much to accumulate because that's going to cause infection. So they put in that drain, they want all of it to kind of leak out as time goes, as it's healing itself. And then eventually they'll take the drain out once they feel like, okay, you're healed up enough, no infection, all good. So typically they'll say return to work in 3 to 6 weeks. That's based on what your work is. The timing will probably be different for someone who's, software engineer versus, like a construction worker. He's doing a lot more heavy lifting, a lot of like that kind of stuff. So it definitely depends, and it varies a lot based on patient to patient. So that's kind of that scale. Diet. So a lot of times after surgery, fluids are the biggest thing. Same thing when you're sick, right? They say take a lot of fluids because your body's in overdrive. You want to give it as much as you can to dilute out all of the stuff that's in your tissues, that's in your blood. Low caffeine, because it's a complicated biological mechanism, but basically you don't want your body not being hungry because it has caffeine. You want to be eating as much as you can, right? But it doesn't matter what you eat. You want to eat something that's high in protein because your body's going to be building up all of this tissue, building up the muscles in that area, building up a lot of different things that require protein, right? And inflammatory molecules, all of that's protein. So need a lot of protein. Low fat. So one of the biggest risks after surgery is stroke, right? Anyone know what a stroke is? Yes. Okay. Kind of, right? So basically a stroke is when you have a blockage of a blood vessel somewhere. It can be due to a lot of different things. It can be a lot of the times it is caused by something called a fat embolus. So it's just like a little piece of fat that is like floating around and gets stuck in a vessel. And then all of a sudden you don't have oxygen to a certain part of your body, which is really bad if it's in your brain, right? But even if it's like somewhere over here, somewhere in your heart, that's really bad because it causes a lot of damage if you don't get oxygen to a certain part of your body. So we don't want that. So, and that is more likely to happen after surgery. So we say, please don't eat a lot of fat. We want to reduce the risk of stroke. Okay. All right. This is a very complicated topic, but it is very interesting. Okay, before I get into it, does anyone have any questions on anything I've gone over thus far?
I have a question.
Yes.
So, like, if there's no like mutations in the gene, but there's like one hit, like one environmental factor, do they still get breast cancer?
So, let's say I'm working in the sun all day and I don't use sunscreen. UV light is going to cause mutations in your genes, right? That if it causes a mutation in a certain gene, that is one hit. That is one hit and they don't have breast cancer or they don't have any kind of cancer. It's only if they have a one hit in that gene and that same gene gets another hit. If that makes sense. It's hard to understand because technically the same genes are all over your body, right? So, the idea is like only certain genes are expressed in certain areas, right? So I have the same genes all over my body, but only like the BRCA gene is the one that works in my breast tissue to control proliferation, right? So if I get a hit on my BRCA gene, um those cells are going to proliferate, right? And certain cells die. So if that mutation doesn't get fixed, at some point, all of your cells will have that mutation. Does that make sense? Yes. Okay. But it won't do anything unless there's a second hit that causes the other good gene that's controlling the bad gene to also be gone. Yes. No. Did I explain that right? Did that answer your question?
Yeah.
Okay. Okay. Anyone else? Amazing. Okay. So this is something we talk a lot about in terms of how do we improve healthcare is there are the social determinants of health, right? So economic stability, neighborhoods and physical environments, education, food, I can't see this. Oh, here. Community and social context, healthcare systems. So there's a really interesting study that got put out. I couldn't find. I'll see if I can find it and send it to you guys. But basically, it was a study about how if you put in your zip code of where you live in America, they can do a pretty comprehensive and pretty accurate prediction of what your health is going to look like throughout your lifetime. Which is kind of crazy if you think about that, right? Because based on your zip code, what can they tell you? They can tell you what kind of education you're getting, what kind of access to food you have, what kind of community resources you have, what kind of healthcare is in that area, um, what kind of people live in that area, what is the average income or salary of a person in that area, right? They know all these things, and those things are so predictive of your health, especially in America, right? So, um, it says the mortality rates have declined, but the overall cancer incidence has continued to grow, right? So, so there's a place in America called the Cancer Belt. I don't know if anyone's heard about it, but it's an area that has a lot of industry and it has a lot of carcinogens in the environment, right? And when this country was being infrastructurally built throughout the course of history, only certain populations ended up living in those areas. Okay, so those populations are exposed to more carcinogens. Those areas are exposed to a lot more stress on the healthcare system, all that kind of stuff, right? They have poor food, all that kind of stuff that contributes towards health, higher incidence of cancer, all that kind of stuff. Occupation wise, sometimes there's a discrepancy between certain kind of occupations and certain kind of ethnicities that um you know are found in those occupations, right? A certain level of education that's found in certain populations, and so all of those things can contribute, right? So what we call like the underserved or socioeconomically disadvantaged populations, if they're not getting a proper education because they have to work to support their families, they may not know what to avoid. They may not know what can cause an increased risk of breast cancer, right? We have so much education and outreach on, wearing sunscreen, on making sure you eat healthy, making sure, you exercise, making sure all of these things. Um, But in certain regions, right, they have food deserts. They don't have healthy food you can eat or healthy food for a proper price, right? If you're not making that much money, the the most convenient thing you can go get is McDonald's, right? Like $5, you're getting a full meal. If I'm trying to put food on the table for my family, um, am I trying to feed them kale? Probably not, right? Like that is such a big um, impact on that kind of thing. How many people have insurance, have the money to go get a mammogram, have the money to go get HPV screening, have the money to go get pap smears? Not a lot of people who have the time or the money to do those things. And that's a huge impact on how much we can treat or how much of an incidence of breast cancer we have, right? The actual overall mortality of breast cancer is going down because more people are getting mammograms, but the incidence in certain populations is going up because um, those are the populations that don't get mammograms, they don't get screened, they don't go to a doctor for preventative care until they're feeling symptoms. And by that time, the stage of that cancer is probably quite far along, right? So it's a very complex issue. It has a lot to do with how much these patients can focus on their health, right? Because they're honestly just focusing on surviving and not necessarily on whether they're thriving, right? So I think a big part of, because everyone in this social strata, realistically, the social strata that you and I are a part of, or that a lot of the people who are doing breast cancer awareness are a part of, they know about breast cancer, they know about the risks, they know about what's going on. I think the biggest impact in terms of awareness and in terms of imparting the importance of screening and the importance of preventative care is probably going to be in those underserved populations and in those specific ethnic groups that are showing a higher incidence of breast cancer. And that might be something that you guys want to look into. What areas have mobile outreach clinics? There are a lot of those, right, that go around and kind of do care for the underserved population. And how can we kind of get the message across that is something important that they would want to do, right? So maybe you can have for every screening you do, you get a free screening 3 years from then, or something like that, right? um, there needs to be a way to motivate people to go do that other than pure prevention, because some people don't have the ability or the time or see the necessity in doing that kind of thing. So I think that could be really helpful. Any questions there? Okay, good. Okay, so what does a mammogram tell you about breasts? So the main thing that they look for when they do a mammogram is density. So what is density? A typical breast will be almost all what we call adipose tissue, or basically cells that are comprised of fat. Fat and glandular tissue is everything that you basically find in your breast. And so if you look all the way on your left side, you see almost entirely fatty. So we don't really see any density. We see kind of the vessels there. We see kind of more of kind of a gray color, right? That's good. We see all fatty tissue. So the way these mammograms work is the more dense something is, or the more hard something is, or the more deposits you see, the whiter it gets. So the whiter it is, the worse it is for us, right? So it's a scattered areas of fibroglandular density. Okay. So if someone's pregnant and they have a lot of glandular tissue, right, that is replacing some of the fat. So a little bit of, they call it fibroglandular tissue. A little bit of that is okay. That's normal. So this side is not dense. And then on this side, it shows it's heterogeneously dense, which means it's just dense in some kind of random areas. That's not a good sign, right? When you have a disposition of cancer, or when you have a higher risk of cancer, that breast tissue is going to start to condense and it's going to start to have deposits in certain areas. So even some mammograms, you'll see like bright white spots, right? And those are certain masses. So this is going to show, when we look at this extremely dense, like that's probably showing us a very high likelihood of having breast cancer. Does anyone know what kind of signs that you would look for in terms of having breast cancer other than lumps? Because I feel like everybody knows the lumps thing, but people don't know other signs. Anyone know any other sign other than lumps for breast cancer that you would see on your breast? No?
If your
Okay, I'm going
skin
to tell you
is,
them.
oh, is it like
Yeah,
if
go
your
for it.
skin is like irregular?
Yes. So it's something that they call orange peel skin. If your skin looks like an orange peel, that is a concerning sign for cancer, right? So if you have little kind of indentations and it kind of feels like what an orange peel would look like a orange peel that's like, a couple days old, kind of really like bumpy and irregular, that is a sign. They call something called skin dimpling. So if your skin goes in a lot in one area and you don't really know why, like the side of your nipple goes in, or there's like a little like indentation that you can like put your finger in, it's really prominent. That is a sign of breast cancer. Indicative, not for sure, can be other things, right? So that's just something a physician sees on a physical exam. So, okay, we're going to get a mammogram, we're going to do a biopsy, we're going to see what's going on there, right? If your breast is like sagging or drooping in a different direction than it normally would, that is something that can be indicative. Yeah, so there's a lot of other signs other than just feeling a lump, because 8 out of 10 times a lump is not breast cancer, right? They can manifest it can manifest in a lot of different ways. So that's important to know also for your PSA if you're telling people about it. What are the other signs of breast cancer? It's not just having a lump. It can be a lot of other things. Okay. Okay, so breast cancer is more likely, any type of cancer. That's not true. That's not true. A lot of types of cancer are more likely when you're older, right? Certain types of cancer are more likely when you're younger. But the risk of cancer overall goes up as you get older, right? Because your body is less able in this time of your life, your body's at its prime, right? It's breaking things down, it's correcting things, it's working at its optimum, right? The older you get, the less efficient your body gets, and it's not as good as at fixing mutations or at protecting your body from certain damage. So as you get older, that's when your risk of cancer goes up, right? And the accumulation of mutations goes up as you get older. So all of those factors together, the older you are, higher chance for cancer. That's just kind of how it works. Menopause doesn't cause cancer, right? We always want to stray away from saying this causes cancer. It doesn't cause cancer. It's associated with cancer because women tend to be, in general, older, and they in general tend to have had a higher exposure to estrogen at that time, right? Because every time you go through your menstrual cycle, your body's releasing estrogen, you're going through that whole cycle. So every time you have that, you're exposing yourself, which doesn't necessarily mean cancer, but let's say you have your 2 hits, you're getting a lot of extra estrogen released into your body, and your cancer is estrogen receptor positive, right? So it's associated, but it doesn't cause, right? It's like this perfect storm that it can contribute to. So women who attained menopause at 55 years rather than 45. So there's two cases that I saw in the research study. So women who hit menopause much later, or women who started their menstrual cycle much earlier, around this age of like 11 or 12. Those women, if you look overall in their lifetime, are exposed to more estrogen. So it just creates more opportunities to possibly get an ER positive cancer, right? So in this study showed that it has a 30% higher risk for women who get menopause 10 years later. That's one study. We can't say that is true, right? But that's what they found in that study. So that's really interesting. But yes. So there is a correlation according to this study. So that's really interesting. So HER2 increases cell proliferation, right? So cell growth. BRCA is something called a tumor suppressor gene, right? So it repairs damaged DNA. So DNA is in a helix and has two strands, right? And they go around each other in a helix like that. And sometimes certain things like sun damage, UV rays, it can cause a break in that whole DNA molecule, but our body has a mechanism to repair that through the BRCA gene, right? So BRCA is what we call a tumor suppressor gene. So in the event that BRCA is mutated, our body can no longer repair that damaged DNA. So now you have accumulation of a bunch of other mutations because the tumor suppressor gene, the gene that normally prevents mutations from happening or prevents damaged DNA, is no longer working, right? So those are the two ways we can get cancer: is progression of a proto-oncogene into an oncogene, or mutation of a tumor suppressor gene. Those are the two ways, okay? And usually those need to happen together. So we need an activation of an oncogene and a mutation in a tumor suppressor gene. So there's a lot of different ways that a gene can be mutated. And gene editing, has anyone heard of CRISPR? Yes, no? So yeah, a little bit. Okay, so CRISPR is basically, someone got a Nobel Prize for it a couple years ago, actually. Is a methodology that they came up with for a way that they can find the mutated gene. They can go in with a certain type of protein that cuts DNA, and they call it a molecular scissors. So they can basically cut out the mutated part and put in a healthy gene. Super cool stuff. Crazy clinical application for this kind of thing. It's super cool. It has not been clinically applied to breast cancer yet. In theory, it could work. They've done some research on it. In theory, it could work. It depends on the type of mutation. It depends on the type of cancer that patient has. It depends on what stage they're at. It depends on a lot of different factors, right? Theoretically, could gene editing, I don't want to say reduce the risk of breast cancer. It can treat breast cancer. Theoretically, gene editing can treat breast cancer, right? If someone comes in and they say, I have a mutated BRCA gene, could they go in and edit your gene so it's not mutated? That's a sticky ground. Right? Because people will say, then where does it stop? Right? If you have a risk for anything and you go into a doctor, could you say, because there's a lot of genes that they found are associated with, obesity, genes that they've associated with risk for diabetes. Like, can any person go in and get their genome read and say, any genes that are associated with these things, I want to be, cut out and replaced? Like, where does that how do we draw the line, right? So it's a lot of a possibility in that area, and lines do still need to be drawn. So at this point, I don't know that they're going to allow patients to do that as a risk prevention. what they call is prophylactically. So what that means is just as a preventative method, right? They won't probably let, I don't foresee them doing that prophylactically, but for treatment, certainly I that can the next decade. My internet connections again. Am I good? Can you hear me?
Yeah.
Is it happening again?
No.
Oh, you're good?
Yeah,
Okay.
yeah, now it's good. That's good.
Yeah.
Okay, great. Sorry. I don't know why it's doing that. But okay, yeah. So anyways, as I was saying, there's only a couple of cancers that they're really using that as a clinical technique to treat. There's going to be a lot more testing and things that are going to need to be done for breast cancer and for a lot of other cancers. So theoretically, yes. It depends on what kind of mutation, depends on how easily it can be changed. It depends, right? Theoretically, yes, but that nothing is being done clinically right now. There's a lot of research that's going into it though to see what can help. Okay, so this is just some general information about BRCA1 and 2. Autosomal dominant, like we talked about. So usually there's a lot more BRCA1 mutations than BRCA2. And so the BRCA1 mutation is generally ER, PR, and HER2 negative, which is a bad thing. And BRCA2 is usually ER, PR positive. So typically to treat cancers, we have something called estrogen receptor inhibitors. So we can pretty effectively slow down or stop the growth of breast cancer cells if they have estrogen receptors, right? Because that's what's causing them a lot of it to grow. So we can slow it down considerably if we have inhibitors for those receptors. So although, we see someone who has breast cancer, that's terrible, diagnosis. If we do a biopsy and we see that it's ER positive, we're pumping our fist because we can treat that. That's awesome. If they're ER negative, PR negative, HER2 negative, it's not leaving us with a lot of specific options that we can treat with. We're going to do chemo, radiation, and kind of see how that works. But generally a poorer prognosis for BRCA1 than BRCA2. Okay. Okay, this is just a kind of a chart that they showed us in our lecture about the whole concept of being autosomal dominant. So kind of just a family tree. You guys can go in and read it a little bit later. It tells you who tested positive for certain genes, who ended up with cancer, who didn't, who died of breast cancer, who didn't, that kind of thing, right? But typically, if somebody in a family is diagnosed with breast cancer, the immediate thought in a preventative sense is to talk to all the family members, right? Do you have any sisters? Do you have any is your mother still with us? Is your grandmother still with us? Do you have any children? All that kind of stuff. Do your sisters have or brothers have children? So you kind of want to inform everyone and have them be much more vigilant about testing and about getting those mammograms. And some people will go as far as to do the gene testing to see if they have BRCA1 or 2. And you may have heard of people, if they find out that they have the gene, they just go ahead and do what they call a prophylactic mastectomy. So they remove one or both of their breasts to ensure that they do not get breast cancer. They do that. Some people will say, that is a lot to do for somebody that you don't know if you're going to get cancer. You may not get cancer. And, you know, as a woman, there's a lot of social pressure and stigma behind that, right? So that's a conversation that they have with their provider of what they want to avoid and how much it's affecting their mental health, to know that they have that mutated gene. And, you know, if they're the type of person where one value kind of overtakes the other, that's a conversation to be had, right? It's not an easy decision to make, but a lot of people do make that decision, and a lot of doctors will perform that surgery prophylactically. So women undergoing breast cancer do often face social stigma. Yep, we just talked a little bit about that. Body image difficulties, absolutely. So are there any screens for distress and stigma faced by women? So a lot more places now are doing distress screenings, and they look at what kind of symptoms people who are going through breast cancer treatment face, and what symptoms contribute most to quality of life issues, right? So really quickly, I'm going to show you this graph. So that's something that one of the RNs that gave us a lecture showed us. There's a lot of studies done on cancer symptomology and mental health that you can look into, but usually they say the number, kind of like the number 1 and 2 for how much the symptoms cause a decrease in their quality of life is typically due to fatigue and pain, right? The feeling that like you can't do anything, and the pain from the cancer, the pain from the chemo, all of that kind of stuff. So those are the biggest things that they found in that study. And what can people do to cope? The nice thing about the stigma when it comes to breast cancer is there's so much awareness for it now, in terms of like breast cancer awareness month, like doing walks and all of that kind of stuff, especially for like higher social stratas. There's a lot of support groups. There's a lot of women who know women who have had breast cancer or who have had someone in their family have breast cancer. And, you know, creating a community has a big impact on mental health, on emotional health, and eventually the health outcomes for that patient, or just like the emotional well-being and quality of life for that patient, right? Because they're going through something that they know other people have been through, and that they have seen other people go through or have heard about other people go through. And that is something that has shown in research has a huge impact on their emotional and mental well-being. So typically we'll call kind of the 3 pillars of support for anyone going through a chronic illness: emotional support, instrumental support, and informational support. So emotional support is what you would think it is, from friends, family, being there with you, having someone to talk to, having met other breast cancer patients, seeing them go through chemo, that kind of solidarity, that certainly helps quite a bit with people's own emotional well-being. Instrumental being, you know, the practical things in life. Is your job giving you days off? Are they giving you, you know, paid leave? Are they giving you certain packages? Are people bringing you food? Is someone taking care of your house? Is someone taking care of your kids? Like all of those kind of things, right? The practical day-to-day things. Instrumental support, because you know, these people still have lives. They have still people around them that depend on them, and especially people with kids, right? So that's a big consideration. And then we have informational support, which is, you know, providers, anyone in healthcare, people like you guys, you know, who are spreading awareness in the community. Like you're doing informational support, right? What could that person have known beforehand that could have helped them, or what can you tell them now that could help them, right? This is something that is going to come up again a little bit when we talk about men having breast cancer. Here it is. Okay, so you know, we talked about emotional support being the biggest contributor to the increase. I also put links to all of the research studies that I got all of this from at the very end, so you guys can go look at those. But the biggest impact for the health outcomes for men were emotional support, right? Their friends, their family, and that varies drastically from man to man. And the chances of a male breast cancer patient knowing another male breast cancer patient is very low. So they have a lot more trouble finding support groups. They have a lot more trouble meeting someone who looks like them, who understands maybe that societal stigma, that kind of feeling of emasculation, or not even knowing what to expect or how to even think about detecting breast cancer, right? Like a lot of girls, if you ask them, how do you know if you have breast cancer? There's like one or two things that they can point out maybe, right? But how many men do you know that if you say, okay, what are the signs of breast cancer? They probably don't know, right? And part of that is due to awareness, and part of that is due to there are not a lot of studies out there. There's breast cancer in women is so well studied, but breast cancer in men is not studied very well at all. Part of that has to do with the fact that it is a very low incident rate, but it does happen. So it tends to be much more difficult for them emotionally in order to receive that social support and to see other cancer patients going through that kind of thing. So that can be really tough. And the disparity on men who do receive instrumental support is very high, right? So a lot of times, especially in the older population, men tend to be the caretaker of the family. And so they're the ones providing the instrumental support for people. And so sometimes, older men who end up with breast cancer, people will either have a lot of instrumental support or very little instrumental support. It's kind of on one end or the other. And then informational support is certainly lacking here as well, as I mentioned. So information on support groups, what they can expect, and how to detect breast cancer. So those are all, some important things that kind of can be used to improve awareness for male breast cancer patients, for sure. And a lot of, for example, women are much more likely, from a research perspective, this is not my opinion, from a research study, women are much more likely to go to support groups, to go to therapy, to go talk to people. Men are less likely to do that. So sometimes that can have an impact on their emotional well-being and their overall health outcome and their quality of life when it comes to recovering from cancer. Okay, so why is it more common for a smaller lump to be cancer? So this is actually, you're more likely to be diagnosed at a smaller lump size, if that makes sense. So 8 to 10% or 8 out of 10 lumps that a person will find on self breast examination or on examination at an office is most likely not cancer. They're usually something called adenomas, which are adenomas. Yeah, I'm pretty sure it's adenomas, which is just like a lump. It's like a cyst. Usually they're cysts. Let's take adenoma out. Let's say cyst. Usually they're a cyst, which is benign and it doesn't really do anything. And sometimes they'll take them out and sometimes they'll leave them there. So it doesn't really do anything. The point at which they'll biopsy a lump and see what it is anywhere between 1 to 2 millimeters. So very, very, very small. And that's for people who are getting regular mammograms, right? So most of the people who are diagnosed were between like grade 1 and grade 2, right? Or stage 1 and stage 2. So when you're at that level, you're more likely to be diagnosed. So usually when people are diagnosed, they have a really small lump. Like it's not super obvious, right? If you have a huge lump, and you're not having other symptoms, it's probably not cancer, right? If you have a huge lump and you're having a bunch of other symptoms, it's probably something is going on that could be cancer, right? But usually people will have gone to the doctor before then, before it gets big, right? So most cancers, when they're diagnosed, are very small lumps. That's the idea. Technically, a bigger lump is a bigger problem if it's cancer. Okay, so don't get that confused. Bigger lump is worse. It's more likely to have metastasized, which means it's worse, harder to treat, worse prognosis, lower survival rate, all that kind of stuff. That article, that research study basically shows that. So it's more likely to be found at a smaller lump size and to cause problems at a smaller lump size than something that's benign is. Does that make sense? Okay, amazing. Okay, are there effective ways to spread awareness that could help with the amount of cases and the number of deaths? So the number of cases hasn't really gone down, that's fair. The number of deaths has gone down actually because of screenings, especially for at-risk population. So if you know that there is breast cancer in your family, you're more likely to go get a mammogram like every 2 years, every year if you want. You know, you can do it as often as you want. So there's a lot of screening that is going on now that is reducing mortality rates, which is really good. Awareness in the community, probably I would say the biggest thing is how big of an impact environmental factors are and staying healthy in general. And you know, nowadays preventative measures are becoming more and more popular, with certain populations being more healthy is becoming more popular. But there's a lot of lifestyle factors that still impact your risk for cancer, right? And the environment that you live in and all these kind of things. So it's hard because when you see a certain level of incidence among certain populations, the changes that need to happen are very infrastructural, right? We want cleaner foods, cleaner environments. We want them to have access to better food. We want them to have access to vegetables. We want them to be able to do all of these things. And that is a really hard thing to say, let's just change that, right? Because that's a hard thing to do. Politics, unfortunately, it's at the center of everything. It's at the center of healthcare. And you know, if there's something you could do, I feel like certainly maybe petitioning insurance companies to make mammograms free, that kind of thing, right? To have insurance companies say, okay, anyone who's on Medicare should be able to I'm saying anyone on Medicare gets free mammograms, right? But certain states have repealed all that kind of stuff. So it's very closely tied to a lot of different things. I feel like in terms of what you guys can do, I definitely think a big part of it is upplaying how important it is to have general health, right? Eating right, exercising well, really paying attention to your health in general, listening to your doctors, taking those preventative steps, making sure you get your mammograms. That's super important. I don't know how many, like, I make sure my mom goes and gets her mammograms, even though we don't really have breast cancer history in our family. It's really important that, you know, we make sure everybody does that because that's how they catch those things. So screening is a huge important factor. Lifestyle factor is a huge important factor. You just have to at the end of the day, think about what barriers people have to getting proper health care, right? And most of the time that barrier is money, right? Which is why people raise money through all these different kinds of ways, because that's how we get access to care to people who don't have it, right? Money is the number one thing. Number two is, do they have time? What is the accessibility, right? If the only place that offers me breast cancer screenings is an hour and a half away, why would I go do that when I barely have time to take care of myself or my family? That's a fair question, right? You can't say that that person doesn't care about their health. They're doing a cost benefit analysis, right? So, people have started doing mobile clinics. They go out to these places. They say, we're going to offer you these services. That's a huge thing, right? So maybe something you guys could do is like find out what mobile clinics are in the area, what outreach clinics are here. Like, you could raise money for them specifically. Say, hey, what kind of screenings do you guys offer, and can we do something to help raise money for that, something like that. I don't know what is in your wheelhouse, what you have the ability to do, or how much time you have for this kind of thing, but those are things people are starting to do to try to help the incidence rates and the early treatment of incidences of cancer and the populations that are most at risk for not having access to the healthcare that they need. Okay. And these are my sources. Any questions or anything I didn't answer that you wanted me to answer?
I don't have any questions.
Amazing. Well, thank you guys for having me. I love doing this. Thanks for listening to me blabber for however long it's been. Oh my God, almost 1.5 hours. I'm so sorry.
No, it's okay. Thank
That's
you
fine.
for
Thank
helping
you.
us. It's a lot of information. It's really helpful.
Okay, good. All right, see you guys.
Check out the 2 videos on your screen and subscribe to our channel as well. Thank you.